Hello and welcome to the Endometriosis Practical Pain Management, Physiotherapy and Endometriosis webinar. My name is Sophie Kelly and I'm the Volunteer Coordinator for Endometriosis UK. We are delighted to be joined today by our guest speakers, Pauline-Clare and Katie Bromley, who will be introducing themselves in just a moment. So before I hand over, I'd like to remind viewers that this webinar is an hour long and it will have a Q&A section towards the end of the webinar where both Pauline, Claire and Katie will be answering live and pre-submit questions on endometriosis and physiotherapy. For any individualised medical guidance, please reach out to your healthcare provider. I'd like to add a little content warning as well. This webinar will include discussion on trauma, sexual trauma, external genitalia and hysterectomies. Our webinars are recorded, so if you feel you need to step away and catch up in your own time, please do so. Without further ado, I shall pass over to Pauline, Claire and Katie.
Thanks, Sophie, and thank you all for joining. This evening, I'll explain endophysio, what it is, what it's not, exactly what it involves, and what to expect and why it is so beneficial. It can be a game changer. And I'll also explain why trauma-informed practice is so useful in endometriosis. So I'd like to start by addressing the barriers and myths about pelvic physio for endometriosis. People worry that it'll hurt, that it will cause a flare-up, that it might be embarrassing, or that it must be internal, and it's too invasive. People also worry that it's just not helpful, and none of these are true. Let me first reassure you that nothing we will do will cause you more pain, and it does not need to be internal. Whilst it is the most accurate and comprehensive way of accessing and examining the muscles, you can opt out if it is with your comfort zone. So you can have pelvic physio without having to have an internal examination. And pelvic physio is not just about internal manual treatments. And we absolutely understand talking about intimate pelvic issues like bladder and bowel symptoms, vulvar pain, menopausal dryness, loss of libido, inability to orgasm and painful sex, amongst other things, can be daunting or seem embarrassing. But we'll do everything we can to make you feel at ease. It'll always be at your pace, and nothing you can tell us we won't have heard in some form or another before. And lastly, and perhaps most importantly, pelvic physio in endo really works. It's exceptionally evidence-based and can be very, very beneficial for symptom management and for endo pain. So moving on to the pelvic floor. The pelvic floor are a group of muscles, get my model, that run the front of the pubic bone all the way around to attach at the tailbone. The pelvic floor muscles surround the pelvic side walls, and they're made up of superficial and deep muscles. So as hopefully you can see from the model here, the pelvic organs, the rectum's a bit squinty, are tightly packed in fact, the bladder's off centre, but the pelvic organs are very tightly packed into the pelvic cavity. So the pelvic floor's role is both supportive and also controls your sphincter. The pelvic floor muscles, which you can see here, I'm hoping, really form the floor of your core. They also share the same nerve supply, the same innervation as the pelvic organs. And as I say, they control our continence. Pelvic floor muscles can be the source of pain in endometriosis, and they can be a really strong driver of continuing pain in endometriosis, even after you've had specialist excision surgery. If you think of any muscle held in a tightly contracted fixed position, like for example biceps, if it's held in a tight position, it's not getting the normal blood flow and can become painful. It'll become stiff and sore. All muscles need to go through their full range of movement, be able to contract, to hold, to relax and lengthen, and the pelvic floor muscles are no different. Lastly, the pelvic floor muscles are highly emotionally sensitive muscles. So if you have had pain down below from perhaps a recent bout of thrush or a UTI or having painful bowel movements rather, your pelvic floor will remember and they'll remind you. So the pelvic floor's role is to support and protect, but in endometriosis, your pelvic floor can become a little overprotective. So pelvic physio is a specialist branch of physiotherapy which provides assessment and treatment of the whole pelvic region, including the treatment of all musculoskeletal and sexual pain. Pelvic physios have done extensive postgrad training in the techniques we carry out, and when we're in training, we examine one another and we practice the assessment and treatment techniques on each other. So we absolutely appreciate how nervous, exposed and vulnerable you can feel. And we also know what the treatments we're carrying out feel like. Referral is through your own GP or hospital consultant, or you can pay for private physio. But please make sure that your private physio is a pelvic physio with experience in endo. And this is our special interest group. So if your private physio is a member and advertising the POGP on their website, you can be assured that they'll have some experience and training in endo. You will be offered a chaperone or support person to come along with you, and consent to any examination or treatment is always fully informed. We will make sure that we explain the risks, the benefits and offer alternatives. And your privacy, dignity and confidentiality will always be maintained, and we will demonstrate cultural and age sensitivity. So what to expect? Expect privacy, expect for it to be at your pace, and have the process fully explained to you. So we'll start with taking a full history. We'll ask you to explain your symptoms in your own words, how your symptoms are affecting your quality of life, what impact they're having on your work, your leisure, your sleep, any bladder and bowel symptoms, any pain with gynae examination or sexual pain or non-sexual pain. We'll ask you about any extra pelvic symptoms you are experiencing and how your symptoms vary throughout your monthly cycle. We'll move on then to a more objective examination. We'll carry out an assessment of your posture, perhaps your gait, your walking, and we'll do a neuromuscular assessment of your hip joints, your sacroiliac joints and your spine. We usually then start the further objective examination by carrying out an abdominal examination. And this is because people with endometriosis can hold lots of tension in their abdominal muscles. And sometimes when we're examining the abdomen, if you've had surgery, we can advise on how to desensitize surgical scars. And then we move on, with your permission, to carry out a visual assessment of your perineum. So that would be your clitoris, your urethra, your vagina, your perineum and your anus. And basically we are checking for signs of skin integrity, tissue health, signs of irritation. We always check if it's okay just to gently part your labia, and we check your nerve supply using a gloved finger. You will be asked to contract your pelvic floor muscles, to cough, to bear down, to try and relax the pelvic floor muscles and let go. And this helps us check the lengthening and the ability to voluntarily relax and coordinate your pelvic floor. We then use a single lubricated gloved finger to check the superficial pelvic floor muscles, and then if you're all right with that, we go deeper just to check the deeper muscles. So it's all done gently, and usually we ask you to squeeze around our examination finger, let go. We can ask you to do quick squeezes and slow sustained hold. We'll evaluate your muscle strength, and any findings will always be shared with you after you're fully dressed, after the examination. Really important to note that you can stop the examination at any time if you feel uncomfortable. It's different from a gynecological examination in that we don't use stirrups, we don't use speculums in endometriosis care, and we're not taking a smear. So, as I said before, an internal examination is the most effective way for us to determine if the muscles are working correctly, and also to access the muscles for treatment. The physio will explain the process. She can talk you through exactly what she's doing, if you like, at the time. And yeah, we'll make sure that the consent is fully informed. So we ask you to sign a consent form, but if you're uncomfortable, you can ask us to stop, and we will stop immediately, and this will not affect your treatment. And the goal setting is highly individualised. So for some people, they just want a bit of help with tolerating gynae examinations or to go through IVF. And any rectal or vaginal examination can be graduated and staged depending on what's easier for you. So there are many endo-related pelvic floor problems, and this is to do with the inflammatory nature of endometriosis, and it will be no surprise, because of the chronicity of pain, because of how long you've been having the pain, that the pelvic floor muscles are so effective. So there's a tendency for tight, non-relaxing muscles, kind of spasmic muscles, and endo-related myalgia is well recognised. We will check the coordination of your pelvic floor, and very often when we do that, we can see that they're tight and short and holding on because of the pain. Endo-related pelvic floor problems can have a lot of problems to do with coordination of the pelvic floors. In order to pass urine, urinary retention is often a frequent occurrence, and you can have difficulty emptying the bowel or painful bowel movements. Some people say that they feel like they're going to pass out just attempting to move their bowels, and that can often be a lot to do with the pelvic floor muscles. And we do a lot of treatment with bladder pain syndrome as well. And another endo-related pelvic floor problem is that sharp shooting pain or burning rectal pain some people with endo can experience. Related to the urination, some people can have problems with a very slow to start stream, a weak stream, or a urinary, like your pee always goes to the left or to the right, or yeah, can be a wee bit tricky. And pelvic physio can help with all of these symptoms. It can be very successfully treated, all these symptoms. Moving on to how physio helps. So how does it help? We'll give you lots of education about normal anatomy and function, advice about your bladder and bowel, and on dealing with the different types of sexual pain, perhaps how to manage perimenopause and menopausal symptoms and the associated musculoskeletal pain, joint pains that often occur. We can advise on the use of vaginal moisturisers and personal lubricants, and lots of our treatment empower you to self-manage. So management of fatigue and flares, and we help you by helping you exercise safely. Generally, we advise against too much abdominally focused exercise like crunches and sit-ups, because these can cause a flare-up in the tightness of pelvic floor depending on your technique. So endophysio really helps to improve your body image and tackles that dissociation that can often occur after experiencing years of pain and symptoms because of endo. So with pelvic physio, one size does not fit all. No two pelvic physio treatment sessions are the same. It's all highly individualised to you. So there are a wide range of treatments these will depend on your physio's experience and your symptoms. But one of the most impactful things that we do is give you contemporary endo-specific pain science education. We do a lot of manual therapy, like hip joint mobilizations and spinal mobilizations. Visceral mobilizations are gentle techniques aimed at restoring the proper mobility of your internal organs like the uterus, the bladder, the colon and small intestine. And myofascial release works on your myofascial to break down adhesions. And you're likely to get pelvic stretches. And these are unique to you. And the purpose of these are to offload and relax your overly tight pelvic floor. Your exercise prescription is likely for your pelvic floor to focus on relaxation, lengthening and coordination, and will address any weakness that we've found by strengthening exercises. And I've included a picture of the clitoral anatomy here because it can be really powerful to understand the arousal physiology when coping with sexual pain. So for sexual pain, we can give you a set of dilators. So we start small because the bigger ones can be a bit intimidating. And these work by proprioceptive stretching and grading exposure, and they gradually increase in size, and we will give you lots of support in how to use these. We can also teach you self-release of your pelvic floor and advise you about using things like the pelvic wand. And these are really useful because they put you in the driver's seat, and you can use these to do the treatments that we would do in the hospital or in the clinic. We can also advise you about things like the penetration barriers. If painful sex, deeper painful sex is one of your issues. Massage, I'm a big fan. Massage is really calming to your nervous system. So we can teach you how to do abdominal self-massage, instruct you how to do vulvar massage and how to desensitize your operation scars, manage constipation, painful periods and bloating. And we'll also give you advice about increasing your physical activity, because we know that exercise releases these beautiful anti-inflammatory compounds called myokines, which help to decrease the inflammatory load. So treatments are vary depending on your symptoms. I'm just about to move on to speak about trauma. Endo as trauma. So trauma is now increasingly recognised as being part of the endometriosis journey. Not for all, but for many. And oftentimes the long waiting lists, the long wait delay for diagnosis, and endo having no definitive cure and often ineffective treatments, poor pain management and high reoccurrence rates after surgery, and endo being so quality of life impacting. Women and those assigned female at birth report that they often don't feel safe in their own bodies. They're always anticipating the next flare-up, worried about pain becoming unmanageable, fear of the future, guilt, self-blame, frustration, and distress for loved ones. And the negative body image due to pain, fatigue, endo belly, irregular bleeding, flooding, bladder, bowel symptoms, fertility worries, and sexual pain, side effects of medication. I could go on. But trauma affects our bodies mentally and physically, whether it's big trauma with a capital T or small cumulative trauma. Endo is a million paper cuts. Endo can feel heavy at times and it can be overwhelming. But we've got you. So what's the solution? Trauma-informed practice. Trauma-informed practice or psychologically informed practice, it's a sensitive approach to your care, recognising how common trauma is. It's 1 in 4 women in their lifetime will experience some kind of sexual trauma, and very sadly, those assigned female at birth are at even greater risk of gender-based violence. So we recognise the impacts of any previous trauma you may have experienced. Trauma can adversely affect someone's lifelong physical and mental health. And people don't always disclose trauma, such as child abuse, neglect, sexual assaults, rape, domestic or partner abuse. So we take universal precautions to work sensitively with everyone, but extra sensitivity with survivors of trauma. We'll not ask you for details. You can share as little or as much as you feel comfortable, no pressure. If you're able to let us know of any known triggers, perhaps examination like certain touches, phrases, positions, let us know. But we're aware that by the very nature of triggering, it can happen unexpectedly. We've got you. We can help you with grounding techniques. And I've treated many patients with previous trauma, and I've worked externally over their clothes and to access the muscles, or we've just worked externally, whatever works for them. Being trauma informed means being able to recognise when someone may be affected by trauma, big or small, and responding in a way absolutely resists doing harm, resists re-traumatization, making things work. So we'll work to develop a relationship with you that incorporates these principles: control, safety, trust, collaboration, choice, and empowerment. And the first and most important principle is safety. So that feeling of physical, psychological, and emotional safety. And we recognise your resilience and we'll help build on it. You are in control. And we know that your tolerance to treatment can vary between treatment sessions. What you can cope with one day may not be what you can cope with the next. Trauma-informed practice truly is patient-centred care. So, Why is trauma-informed practice so relevant in endo care? Because unhelpful things are still being said about endo and endo pain. Hopefully not, but perhaps you've been told some of these things. You don't handle pain well, you're emotional, you're exaggerating, you're a drug seeker, just get pregnant, you're too old, you're too young, wait till after menopause, it's your lot in life. I've heard it all. You're a ticking time bomb, it's a mess in there. Endo can't be causing all your symptoms. Embrace your infertility. You've run out of options. But words matter, and truly they do. And comments like this add insult to injury. Endo's hard enough, and too often endo is not optimally managed, and pain becomes your autopilot. Pain. Your body learns pain and can produce it more easily. And ideally, clinicians will be following the NICE and ESHAR guidance on the management of endo pain, including multimodal pain management with endo physio, because it's so helpful. And I've included this picture here because it's often people report that it was in their teenage or tween years when they first experienced endo pain. However, things are positive. They are encouraging. There's lots of great trials and research ongoing, and there's been improvements in diagnostic screening, and there are many trauma-informed clinicians out there. And there'll also excitingly be a webinar on adolescent endometriosis from Endo UK very soon, so watch this space. So I've summarised what you want your healthcare professionals, be they nurses, physios, doctors, psychologists, radiographers, to understand. Endo pain significantly affects your quality of life. Your pain is real. It should never be dismissed. And you need options, and you need best practice. And remember, trauma-informed practice is patient-centred care, and pelvic physio can be a game changer, especially with endo-associated pain and managing endo symptoms. So I've told you what endo physio is, what it's not, what to expect, and what trauma-informed practice looks and sounds like. I can't stress enough how beneficial pelvic physio is. We are more than the pelvic floor and internal treatments. We're more than the floor and the core. Pelvic physio is really valuable in helping you managing endo journey and endo symptoms. We can improve many symptoms like fatigue, constipation, endo belly, fear of movement, flare-ups. We can help. Increasing evidence points to a multimodal approach to being optimal. That's a whole body approach, utilising lots of different tools and strategies together. And because endo is a whole body condition, you need a whole body solution. And endo affects so many systems of the body, like the musculoskeletal system, the nervous system, the immune system. It really does require a whole body approach. So, my slides are behind here. It can be really powerful to understand contemporary endo-specific pain science, because it helps you get out of that autopilot pain. Because if you're overwhelmed with your pain and your symptoms, you're not fully present. And that's wired into your nervous system. You're just in surviving mode. And by using pelvic physio and all the strategies I've discussed, like relaxation, breathing, pelvic stretches, self-massage, TENS, combine these with exercise, daily exercise in outdoor green spaces, and you've moved from surviving to thriving. also add in a wee bit of mindfulness and you're there. So my top tip is to find some joy and reinstigate achievable, pleasurable daily exercise. And lastly, the optimal approach in endometriosis care is truly trauma-informed. So I realise that this topic can be difficult for some people, but so please do reach out for support if you need it. And I'll hand over to Katie now. Thank you.
Perfect. Thank you for that, Pauline-Clare. So my name's Katie. I'm one of the, I'm a pelvic floor physio, mainly in Tayside NHS, but obviously I'm not from Scotland. So I have come over from New Zealand, from a little town called Invercargill, and I myself have endometriosis. So I'll tell you a wee bit about my story and really the reason why I'm a pelvic physio, because it all ties in together. So I was experiencing endometriosis symptoms pretty much from my first period at about 11, 12. I thought it was normal. It's quite, I've got, my grandmother's got it, my aunt's got it. So my mum thought that what I was experiencing was normal as well. Luckily for me, my dad's side of the family doesn't have any of it. So he was a bit like, that's not really what my sisters went through. So let's get her to the doctor. I had my first surgery when I was 17. It was super helpful in managing mainly pain symptoms at the time, though looking back, I probably did have a lot of fatigue and possibly some bladder and bowel symptoms, but to be honest, I think I just put them down to something else. Being a teenager, going through puberty was hard enough anyway. So my first surgery was super helpful. I went off to uni, absolutely no bother, until I turned 20. And then my symptoms returned with a bit of a vengeance, to be honest. And then I had my second surgery at 21. And unfortunately, that did not go as well. I had quite a lot of bother after that. I was left with significant amounts of pain, a lot of fatigue, some quite severe bladder and bowel issues, a lot of which related to my pelvic floor. So it was the bladder and bowel issues that sent me to a pelvic physio, not really knowing what physio could do for endometriosis. So at this stage, I was at university and I was training to be a physiotherapist. However, I had no idea that pelvic physio was a thing. I wanted to physio the All Blacks, which is the New Zealand rugby team. So I had very my sights set on very different things. So by going to pelvic physio, it really did open my eyes to what could be helped with that. I mean, having mainly just seen sort of sports physio, the holistic approach of pelvic health physio was massively beneficial to me. So there was a lot around managing my pain and fatigue, because they definitely for me came together. So I was really into sports. I played a lot of sports when I was at high school. I played a lot of sports my first 3 years of uni, and then I suddenly couldn't play any sports at all. I was floored by the pain. I couldn't control my bladder and bowel symptoms when I was going back to exercise. Every time I went back, I had a flare up. So that really absolutely floored me, to be honest. But the management around my pelvic floor muscles, a lot of pelvic floor muscle relaxation, something that even training to be a general physio, something I didn't really have a very good idea around. So that a lot of that information around my anatomy and physiology and how to get muscles, those specifically the pelvic floor muscles, to relax, that was all really quite helpful. I was quite, well, in hindsight, I was quite lucky. I didn't really experience a lot of sexual pain, and I kind of haven't in my lifetime so far. Any sexual pain I did experience, I was able to manage with the pelvic floor relaxation exercises that I was going through with my physio at the time with my pelvic physio at the time anyway. So it was massively helpful, mainly around that fatigue management and return to sports. So with pelvic physio, and it was really only with pelvic physio, I was able to finish uni. I was probably not doing as much sports, but I was in my last year of university able to return back to some level of sports, which was a real win for me at the time. It's a real win anyway, but yeah, so back to some exercise. I was able to finish my degree, and then I became a sports physio in Invercargill for 4 years. So I had some connections, obviously, through my treatment a wee bit with some pelvic health physios, both with the university and out with the university, and ended up being convinced to do some pelvic health training during COVID. I think initially I thought it was a bit overstepping to do it when I had been treated for it, but there's just not really enough pelvic health physios, certainly not in New Zealand. So I was eventually convinced to do it, and then once I had done some of the trainings in New Zealand, you do a lot of sort of like weekend and week-long courses, and they all come together to eventually create the equivalent of a postgrad certificate or diploma. So then I was able to work part-time with the New Zealand equivalent of the NHS, which is we call the DHB, and part-time as a sports physio still. So mainly I was working with incontinence and prolapse patients. So not so much pelvic floor relaxation, although I will say it still comes into that, because a lot of those patients can come in with pain as a comorbidity, not necessarily endo specific, but equally that's how I got into going to pelvic physio was through bladder and bowel symptoms. So we all do need a little bit of information around that and training around that, because it can come into our clinics anyway. But then I had a really cool opportunity to merge my sports physio and my pelvic physio, particularly in the youth sector, in a way that had specifically helped me as a teenager. So it was quite a cool way of coming through. So I was already working with youth sports teams, with netball, rugby, synchro swimming, a little bit of basketball, and I was also sports physioing at high schools. A lot of high schools in New Zealand have a sports physio. And then I was able to, with that, work with Endometriosis New Zealand with it's now called Endo Talk, but at the time when I was in high school, I heard this talk, it was called Me, and it's talking to young people who are assigned female at birth about basically about what should our periods look like, what's the anatomy and physiology, what's going on, because we don't learn it when we're a teenager. So learning that was really helpful for me, and teaching it was really, I think, helpful for the people that I taught it to help them get an idea of what was happening, what's normal for our periods and cycles, and when should they be seeking help from a healthcare professional. So and a bit of advocating for themselves, because unfortunately, as Pauline-Clare said, there is some sort of pushback, oh, well, it's normal, oh, you've got periods, that period pain's normal, but actually missing things that you enjoy doing and that you want to do and not being able to come to school for days on end is not normal, and it should be investigated further. So being able to help young people advocate for themselves in terms of their pelvic health, which was really quite nice for me to be able to give back. So I moved over to Scotland in 2022. Obviously stopped doing the talks with Endo New Zealand, but now have really grateful to be back in this zone and working with endometriosis again, in Endometriosis UK, in terms of still helping through pelvic physio. So yeah, it's a wee bit about me and sort of what pelvic health physio has helped me with in the past, specifically related to my endo, because really it all is, and yeah, what I've been able to do and why I'm here. So that's a bit about me. I think we might be on to answering some questions.
Yeah, fantastic. Thank you so much, Katie, and thank you so much, Pauline-Clare. That was a fantastic presentation. We've got a mix of pre-submitted questions, and I saw 2 live questions come in there. So if you do have any questions, just type them in the Q&A chat box. But I'll kick us off with one of our pre-submitted questions, which is, how can we test our pelvic floor at home?
Katie, do you want to take that one?
Yep, so it was, how can we test our pelvic floor at home?
Okay, it's very difficult to test your pelvic floor at home. When asked to do a pelvic floor contraction, normally people will, it'll be a very global movement. So they will, you know, use their abdominal muscles, their inner thigh muscles, their buttock muscles, and everything just clenches. And what you could do at home is use a mirror and just, if you have a look down below and see if you can just isolate the movement. But it is hard to actually test your pelvic floor at home. It would very much be go to a pelvic physio to get an accurate. But you can have an idea of how your pelvic floor, just by how your pelvic floor function is, just by your symptoms. And there are quite clear indicators if you have problems starting your urine stream, or you're having difficulties in painful bowel movements. These things can be an indicator. Painful sex can be an indicator of your pelvic floor having a problem. But it's hard to test at home. But if you can, have a wee look in the mirror and see if you can actually see that kind of indrawing and tightening, but you can't actually tell what's happening in the internal muscles.
Brilliant, thank you so much. Another question we had that was pre-submitted was, how can physiotherapy help with ovulation pain? I was wondering if one of you could answer that question, please.
So ovulation pain, or Mitchell-Schmerz pain, it usually happens about 14 days before your menstrual periods. And what I would advise is localized heats, wee bit of massage, use of TENS and pelvic tilt, sometimes lying on your back with your legs drawn up into kind of frog position. And just putting your hand, you can do over close, just at your pubic bone, and just gently pulling up. Combine that with breathing, and that can be useful. But yeah, it's a tricky one, ovulation pain, but heat, massage and TENS can be very useful for it. Even if you have a Swiss ball at home, lying forward onto your tummy on the Swiss ball, or sitting on the Swiss ball and just doing some pelvic tilting, and that can also help ovulatory pain. Yeah, as well as a couple of paracetamol often takes just the edge off it. I'm not against using a bit of paracetamol.
Brilliant, thank you so much. I'm going to go to some of the live questions we've had. We had someone ask, can pelvic floor therapy help if you've had a hysterectomy, everything but the ovaries removed?
So I would say, yeah, so even with a hysterectomy, a lot of the structures that we're talking about are, well, all of the pelvic floor muscles should still be intact. The other structures, so at the hysterectomy, especially if the ovaries have been left, it takes out one of the pelvic organs. There are still 2 left, so still the bladder and the bowel. There's still all the pelvic floor muscles that could be causing, as Pauline-Clare talked about, some of the issues, sometimes issues with bladder and bowel, but also that they can be overactive, and it is a change in anatomy. So our muscles respond to a change in anatomy. You wouldn't look at any other change in anatomy and think that they hadn't. So same with a hysterectomy, the muscles will respond to that change, and they can be, I suppose, retrained or to relaxed. All the breath work, all of those things aren't changed by the fact you've had a hysterectomy. The techniques remain the same, just the anatomy is slightly different.
Yeah, And if I can just add, Endo UK have a lovely information booklet about hysterectomy on the website, talking about the different routes of hysterectomy and some of the consequences that can happen post-hysterectomy. But one of the things I will add is that when you have a hysterectomy, very often your supporting ligaments can be removed. So they take away the broad ligament, the uterosacral ligament, and so that there absolutely is a change in anatomy. And it can result in you being more risk of prolapse. You can have problems with postmenopausal issues relating to to vaginal dryness and also urinary incontinence. You can be a wee bit more at risk of that. So certainly speaking to your GP about HRT or your advanced nurse practitioner. And yeah, remember, if you still have your part of your cervix or that cuff, that you still need to go for your smear tests. Yeah, but yeah, we can definitely help with after hysterectomy. Yeah.
Brilliant. Thank you so much. We've had a few pre-submitted questions and live questions about accessing physiotherapy for endometriosis. People generally just asking what's the best way to go around accessing that support. I'm wondering if you could offer any advice there.
Sorry, I missed that. I
So,
was looking at the questions. I'm sorry.
It's okay. So
accessing support.
Yeah, how do people go about accessing the support? What should they ask their GPs for?
For a referral to an NHS pelvic physio. Yes, absolutely. There are long waiting lists, but yeah, there is geographical variations as well, but there will be a pelvic health physio in your area somewhere. Yeah.
Brilliant, thank you so much. We've had a few questions around sex and endometriosis as well. One person has asked, how can I reduce pain during sex?
Okay, very, very broad question. You could look at the last webinar where I gave you kind of the top tips, very much working on really good arousal, use lube and use lots of it. Make sure that you have really good communication with your partner, and we can advise on vulvar massage. Sometimes helps to desensitize the tissues. Again, there are different types of sexual pain. If it's a problem of like shallow or pain on that initial penetration, it can be, you know, the dilators can be useful. And if it's not a bridge too far, sometimes we encourage the use of vibrators, because vibrators increase the blood flow and help to relax the muscle. And it also makes it less clinical. But there are different types of sexual pain, therefore there are different treatments, but there's hope out there, you know. And certainly for the deeper pain, we would advise on shallower positions. Remember, most of the nerve endings in the vagina are in the first third of the vagina, so shallower positions, kind of use of pillows and penetration barriers can be helpful.
Brilliant, thank you so much. We have a question submitted live here. Someone's asked, how can we adapt exercises during a flare-up, as you mentioned, minimizing core exercises?
Yep. So definitely avoid that purely abdominally focused. So avoid your crunches and your sit-ups. Katie?
I would say, so depending on what you're doing, usually there would be like what we call a regression of the exercise, so an easier version. So even if you were still wanting to, like, say you were doing Pilates, for example, most of the time there's a regression of the exercise. So it's making it an easier version, whether that's needing to use a block or a support to help do that, or sometimes it would be if certain exercises flare things up, then that exercise isn't for you today, and maybe subbing it in for a bit of deep breathing for that, or an exercise that is, or a stretch that is comfortable rather than loading the muscle up. But yeah, most of the time there's a regression for the exercise that you can work back to, so that you're not in that painful exercise. You can do the easier version of it, and then when you're feeling a bit better, you can go back to the one that you'd usually be doing.
Yeah. But I would definitely add that even if you're not feeling great, do something.
Yeah, the best thing would definitely be still to, like, even with the question about the ovulatory pain, still doing some really light exercise, and that might be sitting on a Swiss ball and doing some pelvic tilts. It still helps to desensitize the muscles, helps with mental health as well. So all of that comes into it too. So yeah, definitely still important to do it and adapt to what you can do on the day, and that can change as well.
And have some strategies, some movement strategies for calming the nervous system. So certainly there's a lot of research recommending Qigong as well, Tai Chi, just nice, gentle movement strategies. Yeah.
Brilliant, thank you so much. We've had a question from someone asking if pelvic floor physiotherapy can help with adenomyosis as well as endometriosis.
Yes. So you're the bulky uterus, and very much so, yes, because when you think your uterus is such a strong driver of pain, and obviously because of its close proximity to the pelvic floor, absolutely, absolutely can we can be helpful for adenomyosis here. And sometimes it's just a bit of support around your symptoms as well.
Brilliant, thank you. We've had two questions, one pre-submitted and one live, asking how many sort of physiotherapy sessions are normally assigned to a patient.
Entirely dependent. No, I'll let you. It's entirely dependent on your symptoms and sometimes your health board. Katie.
Yeah, I was about to say the same. So we're not limited to amount of sessions here. It's more what we feel is appropriate. I think the key is that physio in particular, we advocate for self-management. So, you know, I suppose to be looking out for would be if someone's saying, oh, you have to keep coming back, then that's not ideal. We're looking to give tools so that you can help yourself and you can manage flare-ups when they do happen, because they happen. It's more, can you manage it? Do you have the information? Do you now have the tools in your toolbox to be able to manage that? That's what we're looking to do. It's not about needing to come into physio all the time. And I would say the sessions can look quite different as well. Like I do a lot of in-person sessions, but also over the phone, that can be helpful too, in terms of a way of having some accountability for what you're doing, especially with, like, say, graded return to exercise, but then occasionally having an in-person appointment. But yeah, it's completely down to you and your case.
Brilliant, thank you.
And as long as your symptoms are continuing to improve. Yeah.
Brilliant. We've had a few questions about physiotherapy at the bowels and rectal pain. Someone here has asked, could you tell me if physio would help shooting rectal pain, and what would that kind of physio involve?
So we would be tackling the muscles around the ano-rectal angle. So these muscles here, the levator and ani muscles, and it's about getting them to relax, release, and lengthen. And sometimes that involves internal release, and we can also advise on the use of you self-managing once we've got you to a certain level with the pelvic wands, for example. And it's about educating how these muscles work and how to kind of properly relax and release. Yeah, and we give you a lot of information about, if you're having shooty pains in the rectum, we would advise you on the use of footstools for trying to open your bowels, not to ignore that call to stool if you're needing the toilet. Try to go when you can. We normally teach you to move to poo, which sounds strange, but making these strange noises and letting your abdominals go when you're trying to have a bowel movement. Yeah, but the shooty pain is normally to do with that spasming muscles, and teaching you breath control and to let it go. We can also do kind of external techniques that teach you how to release these muscles externally as well.
Brilliant, thank you. We've had a pre-submitted question from someone who's asked, can you please give some advice on how to deal with the nervousness about going to physiotherapy, as they had past sexual trauma and are quite nervous about attending? So what would be some advice you'd give someone like that?
I take this one, Katie.
Yeah,
it's absolutely okay to, we get it. It'll possibly be in your notes, but it's all right just to, you don't have to share much. You can just say, I've had a bad experience or a history of trauma. And as I said before, it will be at your pace. It's all very gentle and you're in control. So please let me reassure you that it'll not be half as bad as you imagine.
I think as well, it's important to note on what Pauline-Clare said at the start of her presentation, that when we train as pelvic physios, we practice on each other. So we've got a good idea of what it is, and mind, when you start the training, we're the same. It's nervous. You're nervous because, well, I don't know about you, Pauline-Clare, but they weren't colleagues for me, but they were the physios, and so that feeling we've all had, particularly in pelvic health physio, in terms of the nervousness around an internal exam, whether that's with or without the trauma attached to it. But at least there is a lot of empathy there when you see a pelvic physio, because we know what it feels like. We've been through it to an extent as well.
Yeah. So don't be nervous. We'll be gentle.